So it is entitled Idelalisib and rituximab combinations, but of course I think you could easily add your favorite anti-CD20 antibody in here, and maybe that's something to come in the next year's presentation. I thought it might be interesting to set a little idea of why to do this, and we've talked about this already in this forum. We do know that rituximab is used in the community as a single agent, not just in the relapse settings. Rituximab here is, oh boy, the red. So maybe about a quarter of patients in second line, a little less in third line, but still significant even in the front line. Lots of doctors, for especially unfit patients, like to use single agent rituximab in the community, rightly or wrongly. Why don't we build on that? Why don't we actually see if we can make that even better? Because while we do use rituximab because of its low toxicity, these numbers, I would say, aren't quite as acceptable as we'd like them to be. So we're going to combine an anti-CD20 antibody with targeting the PI3 kinase delta isoform by idelalisib, and we've talked about that, and I'm sure we'll talk more about that as we go. The first trial to kind of highlight here was led by Rick and others, including Steve, and this was a phase 1 trial that looked at combination of idelalisib either with rituximab or ofatumumab. So a simple design, ofatumumab at standard doses with 150 milligrams BID of idelalisib, or rituximab for 8 weeks at a standard 375 dose with 1 or 2 different doses of idelalisib. This was a phase 1b trial, and it looked to treat patients continuously to progression, and then they could enter an extension study as well until they received full benefit or progressed with their disease. And I learned actually yesterday, I think, in the myeloma meeting that for CLL doctors who like this slide, we're not supposed to like it. I was told that myeloma doctors think that waterfall plots are a waste of time. I would say I think this is pretty good data, and I'm going to go ahead and use it, actually. This is, of course, in those 40 patients, the waterfall plot, looking at idelalisib with rituximab or ofatumumab, and this is, of course, the best nodal response, and you can see the vast majority of patients are having excellent nodal responses, not surprising, including many patients who had 17p deletions, and I think we always seize that. When we have 17p deletion patients who are getting these kinds of responses, it definitely means something for us, of course. And in this early trial, 85% of those 40 patients getting anti-CD20 therapy with their idelalisib had a lymph node response. Overall response was outstanding as well, with the vast majority of our responses that we see in this combination being partial remissions and overall responses happening in 17p deletion patients or p53 mutation patients. A small number, but something we've seen in other trials as well. And I won't say too much more about this phase 1 study, except time to response is actually very reasonable, about 2 months at a median. Very important durations of response shown there, and progression-free survival at a median of about 2 years in these patients. So encouraging, and led to our more recent randomized phase 3 trial using idelalisib in combination with rituximab for relapsed patients. These were patients that were considered to be unfit for standard therapy. So these are patients who have advanced SEERS score, perhaps poor renal function, and are really not candidates for chemotherapy. And they've progressed within 24 months of their prior treatment. It was a simple design as well, rituximab combined with idelalisib versus rituximab and a placebo. The rituximab was delivered at 375 on the first dose, and then elevated to a CLL dose of 500, but every 2 weeks for 4 treatments, and then monthly for an additional 3. And then if patients had progression, or as it was designed, a progression, if they were on the placebo arm, they could cross over in an extension study to get idelalisib, or if they were on the idelalisib arm and were designed to, in this design, had progression, they could actually escalate the dose. Of course, in this trial, everybody's well aware that the study was stopped early. It was stopped at an interim analysis with about 50% of the events. And so the follow-up is very short. In fact, I'll show you a little about that, but what we can say now is that all the patients who were on the placebo now have had the opportunity to go on to get idelalisib, and the majority of those patients have done that. There's a little about the patients. I won't belabor all of this, but to say Median age was in the 60s, was around 70, with the oldest patient being in the 90s. So it's important to remember that patient population. Median number of prior therapies was 3, but up to 9 or 10, maybe 12 prior therapies. All the standard prior therapies that you would expect in regimens, including rituximab-containing regimens. The true idea of how well this works, in my opinion, in real rituximab refractory patients, however, remains to be seen. A little more about the patients, and again, not belaboring this, but to say majority of these patients had unmutated IVGH, however, about half or almost half in each arm did have a 17p deletion and or a p53 mutation. I mentioned the SIRS score. The median SIRS score in each was 8 up to 18, so a comorbid population in some respects. Median creatinine clearance was around 60 or 62, 67. In fact, that was one of the criteria that to get in the study. You could have a creatinine clearance of less than 50 to be considered eligible. These are the responses, outstanding responses in the combination of idelalisib and rituximab compared to placebo, perhaps a straw man, easy to knock over, but nonetheless clearly a major advance in response rate by adding the PI3 kinase inhibitor to rituximab. Lymph node responses dramatically, significantly better, and as well as recovery of hematopoietic elements as well. This is the primary endpoint in progression-free survival. The median progression-free survival of single-agent rituximab is not good, not surprising, but hopefully this will change the pattern of the community continuing to do that. We need to do better, and this is one way to do better, I would argue. Adding idelalisib or perhaps whatever your favorite drug is to rituximab might be somehow making that anti-CD20 agent work better. A couple things to note, though, on this. It's very important to note that the follow-up is relatively limited. Even though we look at progression-free survival, we want to follow these patients for a much longer period of time. And in particular, many of these subsets, all of which actually appeared to have a significant benefit in adding idelalisib to rituximab, looking at the forest plot, everything to the left of the tree trunk, all these branches suggesting an improvement with idelalisib, and in particular even in patients with 17p deletions, small numbers of patients, including the mutated IGHV patients, but again, very encouraging in these subsets of patients. This slide was shown earlier today. Again, dramatic improvements in lymph node reduction, looking at the sum of product diameters of the two different arms. And I think that's quite encouraging for advanced patients. We do know, again, that with these agents, and idelalisib is no different, that the absolute lymphocyte count will go up initially, but will dramatically drop over a little bit of time and stay down low as opposed to those patients who were randomized to get the placebo arm. This slide shows you the overall survival. There was also statistically significant overall survival in this important study. Again, though, I caution to say that this is short follow-up, and it'll be very interesting to see what overall survival looks like over a longer period of time. However, very significant improvement, about a 70% reduction in the risk of dying if you get idelalisib with your rituximab versus placebo and rituximab. And lastly, I do want to focus a little on this trial about the adverse events. These are heavily pretreated patients, unfit patients. It's important to keep that in mind. But there was no statistically significant difference between the adverse events in either arm. But I will point out a couple of interesting facts. One is that the infusion-related reactions, I think Paolo is looking at this more in depth, were significantly greater in the placebo arm compared to the idelalisib arm. Maybe that has something to do with reducing cytokine release, and I'm sure it does, and it looks like there's some preliminary data that might suggest that. But it's not just that straightforward. There's something else interesting, because actually the rates of pyrexia were higher in the idelalisib arm, as were the number of patients who got chills. Maybe it's small numbers. It's hard to really sort all this out at this time. I also want to just point out that the significant side effect that we need to think about idelalisib is diarrhea. We're seeing, of course, diarrhea in these patients later on, and I'll talk a little bit more about that in the next series of, in the next trial. If you just look, if you just look at all the serious adverse events in the two different arms, the other thing I would say is that while these were well were equal, essentially, statistically in the two different arms. It is important to note that the pneumonias do occur, and in particular, we're seeing PJP, and the exact mechanism of that cause is not clear, but I've actually have one patient who I've recently diagnosed with PJP after a prior idelalisib therapy. And pneumonitis, these pulmonary complications are important to keep in mind as well. So that's the relapse refractory setting of these combinations of anti-CD20 therapy with idelalisib. How about moving this to the front line for unfit patients? And Susan was kind enough to share her ASCO slides. This manuscript is, as I understand, in development. This is a simple, of course, similar trial of idelalisib and rituximab. It's 375 weekly for 8 weeks. Then patients likewise can go on to an extension study. These are for treatment-naive, older CLL patients. And again, nodal responses, outstanding. Gets to this idea then maybe what I think Rick alluded to earlier is even in the upfront setting, it's hard to think about giving more chemotherapy. Best nodal responses are outstanding, with the majority of patients actually achieving a complete nodal response. And if you look at the responses in this upfront setting, I'm not sure how important in an older patient population getting a complete remission might be. We could argue about that, but I would say it's still encouraging to see that 1 out of 5 patients, small numbers, are getting complete remissions, and some patients at least with 17Ps in the upfront setting. So maybe we can think about a different regimen for these very, very difficult fludarabine refractory like patients, or going to be fludarabine refractory if they have 17P deletions in the upfront setting. Progression-free survival, again, short follow-up, but very, very excellent, including in the small number of patients with 17Ps, which we know typically don't do that well for a long period of time. These are the adverse events in this upfront trial, and I will just say it was overall very well tolerated, but again, it's important to note that diarrhea was significant, with about 23% or a quarter of patients having grade 3 or worse diarrhea. In fact, the other thing to note is that the time to grade 3 diarrhea, or actually it's included 6 patients of these 15 who had colitis, because the definition of colitis by the AE criteria is that they have change in their bowel habits, so this was linked together by Susan. So of those 15 patients, the median time to developing those problems is late. It's around 9 months. So we're starting to having to keep that in mind from our prior relapse study, where patients have very short follow-up. In fact, if Rick could correct me, but I think on the relapse study, the patients who were on idelalisib and rituximab at the time of the interim analysis, they had only been on it for a median of about 4 months. So we need to follow these patients for a lot longer period of time. And I've already said all that. So lastly, in the upfront setting, looking at the diarrhea colitis, it does happen later, as I've mentioned. And in fact, that was the leading cause of discontinuing the drug in the upfront setting. The other thing to note, again, are respiratory disorders that happen early, and maybe we'll have to sort a little bit of those out, but certainly those are concerning for major complications. So I'll just summarize. I've focused on 3, I think, significant trials of combining idelalisib with anti-CD20 therapy. I think the results are outstanding. The phase 1 trial with excellent responses, including 17P deletion patients or P53 mutation patients. The randomized trial showed a highly significant improvement in progression-free survival, overall response rate, as well as overall survival. Again, about a 70% reduction in the risk of death with idelalisib and rituximab versus rituximab alone. These were highly statistically significant endpoints. In fact, if we didn't have this less than sign, the zeros would go way over here, so we had to use a less than sign. In the upfront setting, response is outstanding. Again, small numbers of patients. We're certainly going to see more of that in the upfront setting, and I'll just remind everybody that we need to think about late complications for diarrhea, and we need to sort that out as we move forward.